Right, hello. This week I'm going to be going over anaphylactic shock. My name's Kelsey. I'll be filling in for getting clinical education for the next few weeks. I'll just be going over anaphylactic shock, just because there's been some issues identified in the state. So we're focusing up in anaphylactic shock this week for the Cairns region education session. So, if you've got any questions, just pop them in the chat or put your hand up and we'll get started. Okay, so shock as I guess a subject is quite broad. There's multiple things that can cause this state. Classically, you've got a volume issue like bleeding, you've got an obstruction issue like tension or tamponade. You've got cardiogenic, of course, the pump is not working due to, say, a rhythm or uh, a akinetic chest wall, myocardial wall, um, or you've got a distributive issue. And the distributive issue is the one we're going to talk about today, and that includes things like sepsis, anaphylaxis, and also neurogenic shock, depending on your how you define it. But shock is a state really as a degree of organ dysfunction due to lack of perfusion. So you often will see hypotension, plus or minus, like often tachycardia. But there are obviously some states where you may not see that in cardiogenic states. But you can also measure your degree of end organ dysfunction with lactate. And it's a bit beyond we don't really have the time today, but generally increased lactate or a trending of increased lactate that gets worse, not better, is a bad sign. And that's just a measure of your anaerobic metabolism or degree of that anaerobic metabolism. So improving lactate is good. The worsening lactate over a number of hours is bad, of course. Today we're going to be talking about distributive shock. So we see sepsis as one of these. It's quite, we can't really, don't have the time to go into it today, but you get sort of mediators that may or may not be due to the microbe or the offending microbe. That's just beyond today's talk. Anaphylactic shock, though, traditionally anaphylaxis, is IgE mediated. But since with the recent changes, anaphylactoid reactions, which typically are things like hereditary angioedema that are non-IgE mediated, we all just categorize these all as anaphylaxis now. So none of that old anaphylactoid anaphylaxis. Make it a bit easier. But generally, your most severe anaphylaxis are IgE mediated, your immunoglobulin E. And this just basically means that you get a lot of mediators, such as histamine being released by your mast cells, basophils. There's many different mediators, prostaglandins and leukotrienes and all sorts of things. We do not have time to go through all of them because we've only got 20 minutes. But next slide. So what are we going to see in this patient? Well, you could see all numbers of things. Traditionally speaking, in your classic patient, you may see some cutaneous symptoms. So macropapular rashes, erythemas, urticaria, and you might see respiratory symptoms such as bronchospasm, stridor, or you may see a cardiovascular collapse, edema, and all sorts of those sorts of things. You can also just have two of. Is another criteria to make it, well, supposedly easier. You might see a respiratory issue, a cardiovascular issue, a cutaneous issue, or a sudden GI upset, like nausea, vomiting, tummy pain. So, and the third one, just to be noteworthy of, is if you do have someone who knows that they've been exposed to an allergen and they have a reduced blood pressure, without any other symptom, if that would be anaphylaxis as well. So, but you obviously need to know, or the patient may tell you that they've been exposed to an allergen that they have. So exposing the patient is very important. There was a case study over in the US where they didn't have a look under the prison jumpsuit, and so that patient did not get any adrenaline for quite some time. So you do need to have a look. Have a high index of suspicion in your patient with collapse. for example. Now, this is our guideline. We should be all very familiar with it. Level. Just remember that it has changed from 2 doses of IM, 3 doses of IM adrenaline. Now you just have 2 IM doses of adrenaline. So, and after those 2, we can start looking at adrenaline infusions in our second line of treatment, and that's sort of symptom driven. So if you've got a persistent wheeze, then maybe with steroids and salbutamol, for example. But we should be pretty familiar with this one. Now, adrenaline, it is our primary treatment for anaphylaxis. We just know it works. There's no control trials for adrenaline, but we just know it works. Just an interesting note. But how it works, we remember that it does have that beta 2 agonism for bronchodilation, your pulmonary effects, and you've also got a vasopressor effect in your alpha 1 agonism. It also drive up your myocardial contractility with your beta 1 effects and your chronotropy with beta 1 effects. And this is where you start to get issues with arrhythmogenic effects and maybe some ischemia. So you do have to be careful. It does have a few issues with it, they're more so than something like noradrenaline. But it also helps with angioedema. And again, there's no evidence to say that IV adrenaline is the best option initially. Just go with those IM doses up until that you can get a infusion set up, because that's the safest way to do it. So yeah, just IM doses of adrenaline, and then keep going with that until you've got an infusion ready to go. Traditionally, with other treatments, we've always thought steroids. There's not really too much evidence with whether steroids are actually beneficial in this group. It does not appear to reduce whether these patients reappear to ED in the next week, but it is still something we traditionally do until more evidence comes to light. Antihistamines, they are useful in your minor reactions, and let's say that you've got a successfully treated anaphylaxis and you do no longer require any adrenaline, but you've got some leftover pruritus. This might be one area where antihistamines might be useful, but whatsoever do not delay adrenaline or loratadine. And of course, fluid loading is very important. Fluid loading and adrenaline is much better than adrenaline alone or fluid loading alone. So just give adrenaline and fluid loading would be very good. So we're going to move on to our adrenaline infusion, and so best to do that via a pump. We're going to start around 10 mics a minute and titrate to effect. You're going to titrate every few minutes. We're going to keep watching blood pressure, having that cycled every 3 to 5 minutes. 3 minutes probably until you're you're used to how the patient is trending. You're going to watch that blood pressure. You're also going to watch your ECG monitoring. That's also quite important because it can be quite arrhythmogenic. But all of that press doesn't really work unless your patient is adequately fluid loaded. So just ensure that you have adequately fluid loaded, whether that's 10 to 20 mils per kilo, or, for 1 to 2 liters for adult. Obviously being careful that you're not causing fluid overload and pulmonary edema in your patients with comorbidities, or they're a bit older. Just being cautious in that sense. So you've given a few doses of IM adrenaline, and you're probably now looking at refractory anaphylaxis, which is not a very good state to be in, to have. There are some risk factors for whether it's whether you're going to see refractory anaphylaxis. And whether it's more severe and undertreated with adrenaline tends to be where you get issues with biphasic anaphylaxis or refractory anaphylaxis. Certainly, the one way to have a worse presentation anaphylaxis is if you're giving intravenous drugs and that triggers your anaphylaxis presentation. So things like intravenous antibiotics are quite high risk, seeing as that normal penicillins result in reactions. So intravenous penicillins are a bit worse again. And then of course your anesthetic agents like your neuromuscular blockade agents. Those can be particularly nasty, and there can be why you often see your arrests on induction in theatre. It's generally because of these drugs, reactions to them. So that can be quite nasty, especially if you're giving RSI drugs to patients. This might be something that you need to be considering. And then if you've got an underlying cardiovascular disease, this can also lead to higher risk or risk of treatment. And of course, that delaying adrenaline does lead to a greater mortality and morbidity risk, but it also, weirdly enough, reduces your responsiveness to the adrenaline that you end up giving, which is a very interesting phenomena. So there's two reasons there for you don't want to delay adrenaline, because it, one, increases the risk just because of the time delay, but it also reduces the effectiveness of the adrenaline that you end up giving. That's important. So sequelae of prolonged hyperperfusion are very much in the same vein as your regular shock. In that with AKIs, we see AKIs in hypovolemic shock in the same way, but perhaps in a greater degree with the circulating inflammatory mediators that you see in anaphylactic shock. But these are quite significant. Remember, AKIs, your kidneys are often the target of your mean arterial pressure that you'll target with your vasopressors. So, but that's generally something you look at when you're looking after these patients a bit longer than we do. Cerebral hyperperfusion is an interesting one. It's a bit hard putting together studies in patients in anaphylactic shock, weirdly enough. So it's only in a rat model, but they found that whilst in mild anaphylaxis, the cerebral flow was similar to that of cardiogenic shock, in more severe anaphylactic shock, they had markedly reduced cerebral perfusion pressures, not consistent with what they'd expect, which is very interesting. This may be due to some of the mediators involved in this condition, particularly platelet aggregating factor. So there's another reason why treating this aggressively is quite important. You almost might see some coronary hypoperfusion, and this is either both because of some adrenaline-mediated issues, if in an iatrogenic way, that you're giving quite a bit of intravenous adrenaline, and you're, I guess, pushing that heart too hard. But it also can be due to something called Kuhner syndrome, which we'll have to talk about in another slide. Now, acute respiratory distress syndrome, another condition that weirdly pops up with anaphylaxis, which we'll be exploring in another slide, and prolonged hospital stay. So morbidity, ventilator-associated pneumonias, and of course increased cost. Okay, so the challenges that you're going to face with these patients that are on, you're starting to up-titrate to quite high levels of adrenaline infusions. Again, that Kuhner syndrome, which has its own dedicated slide. you may see persistent anaphylactic shock that's quite resistant to the levels of adrenaline you're giving. These patients have required extracorporeal membrane oxygenation in the literature, which is quite a significant undertaking, as you can imagine, quite costly and resource consuming. And if you're getting patients to that level, then of course you're seeing many that require multiple vasopressors like noradrenaline, which just tends to have a bit of a stronger press rather than the chronotropic and inotropic forces that adrenaline tends to have more of a vasopressor effect, and just juggling between that arrhythmogenic issues that you have adrenaline as well. You can see biphasic reactions, and these are quite tricky, and why tends to be why. I mean, again, if you've got a patient with an adrenal infusion, I suppose it's safe to say that you're going to transport that patient to hospital, hey? But in your less severe anaphylaxis and patients quite resistant to being assessed at hospital, this is again where an issue tends to be. In patients with delayed or adrenaline requirement, they can have an incidence of biphasic reactions, and this tends to be somewhere in the vicinity of 5%. But those values, they do tend to change a bit, or at least depending on the author. You have quite a few issues with your duration of monitoring that's required, and that might be anywhere from, again, from the exposure to 8 hours, but this can happen anywhere like beyond a day later. It's quite broad, it's quite difficult to predict. And if you're seeing this patient during this, I guess, representation of this, like the biphasic reaction, then it can be quite tricky recognizing that this is anaphylaxis without any exposure. That's important to note. Acute respiratory distress syndrome. Now, scary enough, this has appeared in several case reviews, and it's quite, to put it really bluntly, it's a ventilation nightmare. You have really stiff, non-compliant lungs, and really quite impaired gas exchange. This may be related to fluid loading with inadequate adrenaline dosages, so just be careful with that, and just keep in mind that if your ventilation is requiring increased pressures and with worsening gas exchange, that this might be starting to develop. Just keep an eye on your ventilation pressures as well, would be good. Kidney syndrome is one of those things that I didn't know anything about before this this presentation. It's a really interesting phenomenon because it can happen in children as well, which is very interesting. Type 1 is quite interesting in that you're getting ACS symptoms, chest pain, maybe even troponin leaks, in a patient with nil pre-existing cardiac disease, and this might happen in children as well, and this is because of a Prinzmetal's angina-like coronary spasm. It may be due to the histamine release in the large amounts of mast cells in the myocardium. But again, there's nil pre-existing disease, which is what makes it type 1. And drugs that help reduce that spasm are what are going to be useful. And they're not really things we have. We only have pain relief, unfortunately. But that's just interesting to know. Type 2 and 3 really both refer to existing disease. The type 2 being that there is atherosclerotic disease and that there is a spasm or a rupture in that disease in the setting of anaphylaxis. Or type 3 is that there is a thromboembolism or an issue with an actual stent hardware that's pre-existing. So this thought that with the stents, that because stents are obviously quite prothrombotic, they interfere with the drug-eluting properties. You're treating it as ACS with very important modifiers, pain relief, but you've got to be careful of the blood pressure. Adrenaline, but you've got to be careful of the the chest pain. So, very tricky. Any questions, please let me know, and I'll see you next time.